Great, thank you. So hello, my name is Adina Greenbaum. I'm the Assistant Commissioner for Clinical Services and HIV and STD Prevention at Baltimore City Health Department. I'm an infectious disease physician, and I don't oversee the opioid programming at the health department, but I'm going to try my best to channel the expertise of those who do. So I have nothing to disclose. So I've been asked to speak for a few minutes on the opioid crisis, so I'll briefly outline where we are nationally and then discuss the local epidemiology and some of the health department's responses and activities, and then briefly discuss the role that I think physicians can play. First, just to ensure we're all on the same page, I know I'm speaking to physicians, but I always like to clarify that when I'm speaking of opioids, I'm referring both to illegal drugs such as heroin and then also prescription pain relievers. So obviously just talking about opioids doesn't necessarily distinguish whether what drug substance you're talking about and whether the use of it is legal or not. So I'm going to start with a brief review of the opioid epidemic nationwide. So when we talk about the opioid epidemic, we're talking a lot about deaths. So all my graphs are pretty much on deaths. So we're seeing astronomical numbers and rates of deaths due to opioids in the country, numbers which we have never seen before. And it has really hit crisis levels all across the country, including here in Baltimore. This graph shows the death rate per 100,000 population due to overdoses in the United States for the past 50 years. You can see a sharp increase beginning in the mid-1990s. It also shows how causes of overdose have changed over time. In the early stages, in the late 1970s, most deaths were due to heroin. Then in the late 1980s, started seeing more cocaine-related overdoses. And since the early 2000s, opioids have been the main driving force behind deaths. So this problem, while always around to some degree, has aspects which are new and different and is on a much larger scale than what we've seen before. So now we'll take a closer look at the more recent opioid epidemic. This graph shows more recently what's contributing to deaths. In wave one, from around 1999 to 2004, most deaths were due to prescription opioids, the purple line. Wave two started around 2010, and we started seeing a rise in heroin-related deaths. And wave three, which started around 2013, we started seeing a rise in synthetic opioid-related deaths, including fentanyl, tramadol, and carfentanil, another synthetic opioid that has shown up in street drugs and has been responsible for overdoses. I wanted to point out this photograph, which always shocks me. This photo shows equivalent doses, and I believe it may be fatal doses, of each of heroin, fentanyl, and carfentanil. Carfentanil is 10,000 times more potent than morphine and 100 times more potent than fentanyl. Fentanyl is 50 times more potent than heroin. And problems, of course, occur when people think they're using heroin, but it is in fact laced with fentanyl or carfentanil. This graph is another depiction of death rate by drug type, showing deaths per 100,000 population and the number of drug overdose deaths in the gray bars in the background. Blue, the top darker blue line on top is total deaths. The lighter blue line underneath are deaths due to commonly prescribed opioids. Red are deaths. The red line is deaths due to heroin, and the green line is deaths due to synthetic opioids. And this graph shows death rates, not total deaths, but death rates by race since 1999 nationwide, certainly showing disparities by race. So the lighter blue line on top is among non-Hispanic American Indians and Alaskan Natives. The darker blue line is among non-Hispanic whites. The lighter red line is among non-Hispanic blacks. The darker red line is among Hispanics, and the green line at the bottom among non-Hispanic Asians and Pacific Islanders. And these graphs show death by age group and drug type, and I'll just focus on the last one for 2016. And the take-home message from this, I think, is that for multiple different drug types, the deaths range over a large age span, but you certainly see a fair number of deaths in the younger age groups, which is, of course, concerning. So I'll spend a few more minutes talking about the role that prescription drugs play. This graph shows how opioid prescriptions nationwide have increased since the early 1990s and then have been starting to level off more recently. And when thinking about prescriptions in the opioid epidemic, here are some numbers that I thought were telling. Up to almost 30% of patients prescribed opioids for chronic pain misuse them. Up to 12% of patients develop an opioid use disorder at some point in their lives. 4 to 6% of those who misuse opioids transition to illicit opioid use later on. And 80% of those who use heroin first misused prescription opioids. So really showing the link between what's being prescribed and then drug abuse later on. So now I'll spend a few minutes talking about the opioid epidemic in Baltimore City. This shows metropolitan counties with the highest overdose fatality rates in 2016, and you can see, unfortunately, Baltimore City is at the top of this list with fatality rates higher than some other cities, including Pittsburgh, Philadelphia, Cleveland, and Washington, D.C. In terms of overdose deaths in Baltimore City, they've increased from 2011 to 2017. In 2017, there were 761 overdose deaths. The graph is now updated, not just Q1 through Q3, but all of 2017. And we're estimating at least 800 deaths in 2018, so even more for last year. By comparison, there are around 300 homicides in Baltimore each year, and that's certainly, in thinking about the amount of press and about the amount of attention it gets paid to the homicide rates in Baltimore, can help put the opioid epidemic in perspective. And of note, 20% of the deaths that are in Baltimore are not from Baltimore residents, but from people who are not residents of the city, but come into the city to buy and use drugs and then overdose in the city. In terms of fentanyl-related deaths specifically, they've drastically increased more recently, with 573 deaths in 2017. And then this shows prescription opioid-related deaths in Baltimore City with an interesting pattern, with levels a little higher in 2007, decreasing for several years, and then increasing more recently. So what are we doing at Baltimore City Health Department in response to this? Well, we're certainly thinking a lot, and I should have changed it, shouldn't say addiction. For some, addiction is a stigmatizing term, so tend to stick more with substance abuse and misuse. But there's over 25,000 people in Baltimore City with opioid use disorder. Evidence-based treatment does exist, and it works. There's medication-assisted treatment, which combines medication therapy and counseling, which we certainly know does work for people, but fewer people get it than what the need is. Only 1 in 10 who have the need complete it and are able to access it. But treatment does cut mortality in half or by even more. And the National Institutes of Health has estimated that it's also cost saving. For every $1 spent on treatment can save $12. So what are we doing? Well, we're certainly trying to expand availability of treatment. We're also expanding syringe exchange. So for people who use needles to inject drugs, and then if they're, in order to not use dirty needles, they can come and exchange their needles. And at those locations, also having counselors and other availability for referrals into drug treatment, increasing access to drug treatment, especially among primary care physicians. So getting it out of just a specialty setting and having it be more available. And really having a stigma reduction campaign to reduce the stigma around drug use. A key component of our campaign is increasing access to naloxone. There's a citywide standing prescription for naloxone, and last year the requirement to have training for it was removed. So for the most part now in the city, being able to get naloxone is very similar to an over-the-counter medication. We also have naloxone distribution centers to try to get the drug out to people who need it. We've established a stabilization center, which is a facility staffed by nurse practitioners and nurses and case managers and social workers to divert some people from the emergency rooms who have substance abuse problems, and that's really their only reason they're in the emergency room, into this center where they can then go on to a safe discharge and access the resources that they need, including drug treatment. There's law enforcement assistant diversion, where people who are arrested of low-level offenses can choose to go into treatment or other services instead of going down the judicial system route. We also have several overdose review boards and task forces which convene various stakeholders in the community to discuss various interventions. And last year, the levels of care for city hospitals was released, where all the city hospitals get ranked on what their response is and what services they have for the opioid epidemic based on the number of services that they provide. So in summary, opioid deaths continue to increase. Many are calling this the epidemic of our time, and it's truly a public health emergency. There have been some improvements nationwide in prescribing practices, but there's much more room to improve, and our interventions have to be policy and system-based, not just based on individual people, but prevention is key, and that's really where physicians can play a role. And given what we know about the abuse of prescriptions and how they can eventually lead to abuse down the road, and really decreasing the stigma associated with substance use and abuse and increase access to treatment and naloxone. And just trying to emphasize the message that substance abuse is a disease just like diabetes or hypertension, and that treatment for it is just like treatment for any of those other diseases and shouldn't be treated any differently than that. So I'm very sorry I'm not able to stay for more of a question and answer session, but I really want to thank you and thank the conference leaders and moderators for just recognizing the important issue that this is, for setting this time aside to talk about it and to talk about what your role should be, and for inviting the health department. So thank you.
Thank you.